Hi, everyone. Welcome. Our webinar is going to begin shortly. Hi, everyone. Our webinar will begin shortly. Okay. Welcome to the assessment of chemotherapy drugs in occupational settings. So a few housekeeping items first. You will be muted during this presentation. If you would like to ask a question, please enter it into the online Q&A box. We will save time at the end of the presentation to address as many questions as possible. This presentation is also being recorded and will be made available on the Center for Occupational and Environmental Health's YouTube page. All participants who are logged in with their registration email for the full live presentation today will receive an email tomorrow with a link to an evaluation form that will qualify participants for a certificate of completion worth 1 continuing education contact hour. And once this evaluation is completed, you'll be able to access and print your certificate. So at this time, we are pleased to announce our presenter, Andrew Floeder. Andrew is a fourth-year PhD student at the University of Minnesota School of Public Health in the Division of Environmental Health Sciences, studying occupational and environmental epidemiology. He works in the labs with Dr. Susan Arnold and Dr. Sylvia Balbo at the Sonic Cancer Center, analyzing exposures from different environmental sources that lead to DNA adducts using mass spectrometry. He also worked on several projects with Dr. Susan Arnold looking at the surface contamination of chemotherapy drugs in veterinary oncology clinics to help improve decontamination protocols and reduce potential secondhand exposures, which is currently the focus of his doctoral thesis. So welcome, Andrew.
Hi, thanks, Tara. So I will get started. Okay. So yes, today I'm going to be talking about the current focus of my doctoral thesis and specifically looking at veterinary oncology clinics and the potential risk for antineoplastic drug exposure. So first, I'd like to thank the Midwest Center for Occupational Health and Safety for funding this research that I've been able to accomplish, as well as several pilot projects that we've been working on. And we can get started. So exposure to chemotherapy drugs has been increasing. In 2020, the American Cancer Society predicted there'd be more than 1.8 million new cancer cases. And this is an increase of over 55% compared to the last 15 years. So this also correlates with an expected 58 million patient oncology visits in the clinic in the United States. So as this cancer incidence and chemotherapy treatment has been increasing for humans, it has also become more common for dogs. So an estimated 1 in 3 dogs develop cancer, and this is the leading cause of death in dogs. So antineoplastic drugs are increasingly more administered in these veterinary oncology clinics. That being said, it really begs the question is what is the effect of these drugs on providers? And research has already been drawn to show the main mechanisms of action for these chemotherapy drugs. They're designed to target fast-growing cells, but they're unable to exclusively target these cancer cells. So this often results in the death of healthy, normal cells in patients. So that being said, as you're having more chemotherapy being administered in the clinic because of the increased patients in these oncology clinics, there pose a question of inadvertent health risk towards the occupational workers in these clinics. So through various studies, these occupational inadvertent exposures have been well established. They lead to detrimental adverse health effects such as cardiac, reproductive, and genotoxicity seen within nurses and other oncology technicians. And there are also other adverse acute health effects such as hemorrhagic cystitis or spontaneous abortion seen. So overall, this scenario may lead to increased exposures for patients, nurses, family members, and caregivers to these antineoplastic drugs that we're seeing. So that being said, chemotherapy use in veterinary oncology clinics is increasing. So dogs are being treated with these antineoplastic drugs, and this may be a potential secondary source for exposure. However, the extent of this exposure and as dogs of a host for this exposure is relatively unknown. So the goal of my research has been to look into the levels of chemotherapy contamination in veterinary oncology clinics to see if we can identify and measure that level of contamination, as well as in patients' home environments coming from that secondary source of dogs leaving the clinics after treatment. So today I'm gonna cover two specific aims of my research and break them down by project. So first, we're going to talk about the establishment of a liquid chromatography tandem mass spectrometry method that we will be using to identify potential chemotherapy contamination from commonly used drugs in oncology clinics. And then we will be talking about how we went about validating this method for clinical applications. So the initial liquid chromatography tandem mass spectrometry method was adapted from a previous protocol with modifications to implement it in our new working method for our lab. So we focused on the detection of 6 unique antineoplastic drugs. These were cyclophosphamide, doxorubicin, fluorouracil, methotrexate, paclitaxel, and etoposide. These drugs are commonly used drugs in both hospitals, in oncology clinics, and in a veterinary oncology clinic, which was mainly our criteria for the different types of drugs that we would choose to include in our method. So as we began with our method development process, the first thing that we had to do was do a direct infusion into our mass spectrometer. So this was done in order to identify the parent ion of our chemotherapy drug and its potential fragmentation ion. So when we're doing direct infusion, our output may look something like this with our chromatographic data. So as we can see here, we have cyclophosphamide. And with cyclophosphamide, we're telling the machine to specifically identify its parent mass that it's triggering right here, this 261. And then we go through and we're using this because we're directly injecting a known solution and concentration of the drug onto the mass spectrometer in liquid form. With that being said, we are looking into the literature and reading about the parent ion of the drug and then known fragmentation ions of cyclophosphamide. So with those fragmentation ions, we're able to create parameters that better suit for this specific drug and look at 2 specific fragmentation ions that are listed here, a 119 and a 140, that have been confirmed in the literature to be from the fragment of the parent ion. And that way we will have 2 drugs and 2 fragment ions for our one specific drug that can be used as a quantitative ion and a qualitative ion to really make sure that what we're seeing is specifically coming from cyclophosphamide. And then to further help our analysis with our validation later on, we included the deuterated labeled standard for each respective chemotherapy drug we're including. So for cyclophosphamide, we have the labeled cyclophosphamide D4, which should react the same as the unlabeled cyclophosphamide, but we'll be able to spike it into our experiment to make our analysis quantitative. That being said, once we had accurately identified all of our parent ions in chemotherapy drugs and their fragmentation ions, we moved forward to optimizing our LC-MS method. So when you're testing your method, there are a variety of different parameters and conditions that you can test. You can test different mobile phases and solvents for your analyte of interest. You can test different columns that may reflect different polarities that you're looking for. You can try different injection volumes or different collision energies. So there's numerous different parameters that you can test, and each is important into getting nice, accurate, sensitive data. So when you first start out with your compounds, grouping all of them together for a simultaneous detection, you may end up with something like this, where you're seeing specific peak shapes that represent our data points that are clustered together. They're not fully separated from one another. They don't have clear starts and clear ends. And it's hard to use this data to accurately identify something in a sample. So what you do is you change the method parameters, and then you'll end up with data that more is easily able to identify the specific things that are in your sample, and you're able to accurately say what they are. So that being said, a lot of work went into the method development. If anyone has any questions at the end, I'd be more than happy to cover it in more detail. But for our first aim, we were able to create a method for the simultaneous detection of 6 chemotherapy drugs. These were molecules that had never been combined before using our LC-MS approach, and they included both quantitative and qualitative ions. This also meant we had increased sensitivity for multiple ions at once, especially changing different ionization energies in one mass spec injection, switching from ESI positive to ESI negative. That being said, we had just developed this method and we needed to validate it before we moved on into our clinical application. So what we did is we did in-laboratory testing in order to validate our method. So on the left, you'll see a 100 centimeter stainless steel plate that we use for the laboratory testing for the spiking experiment, which is reflective of our template that we used for the clinical surface wiping once we moved on into the oncology clinic. So our workup for our validation looks something like this. We would spike the stainless steel plate with a set amount of our drug stock solution. This drug stock solution had all 6 of our chemotherapy drugs spiked into it. And then we would let the sample sit on the plate, let them evaporate for 15 minutes before we then wiped them with a wipe. And then that wipe went through our deabsorption process in order to get it ready for our mass spec analysis. So in doing this, we spiked known amounts of the labeled internal standards alongside the drugs in order to quantify our limit of detection, limit of quantitation, our recovery, and then our specific method recovery limits. So with this validation, adding on to our other goals from the specific aim 1, we were able to establish a lower limit of detection and a lower limit of quantitation that had been previously published in other papers and methods. We had drug recoveries ranging from 45 to 80% for 6 different chemotherapy drugs, which is consistent with what's out there in the literature. And then we also had comparable method detection limits per surface, which is our specific detection limit for our wiping method that we're implementing for other previous methods. So overall, the findings for specific aim 1, we were really able to create a LC-MS method for the simultaneous identification of 6 chemotherapy drugs, which was really important in order to have just one sample that's then run through the mass spectrometer once. And that being said, we are able to accurately identify each individual drug and then quantify them from their labeled internal standards. This was then validated with our in-laboratory wiping, looking at our LODs and LOQs, the recoveries, and method detection limit per surface, in order for us to say that we had a nice comprehensive method that will be able to move to the clinical aspects of this wiping. So moving on to specific aim 2, this aim focused on applying our method to see if we are able to detect any potential surface contamination from antineoplastic drugs in veterinary oncology clinics. So we conducted surface-wide sampling following the treatment of dogs from chemotherapy drugs. So we were looking at two specific types of surface-wide sampling. The first was conducting sampling from commonly frequented or touched areas inside the veterinary oncology clinic. These could be door handles, the treatment table, the syringe, or other areas inside the veterinary oncology clinic where the oncology technicians had frequently handled or touched after using the antineoplastic drugs. And the second source of surface wiping we were interested in were the dogs after treatment as a source of secondary exposure. So the dog wiping is actually still ongoing, and I'm actually collecting a sample later today from that, so there won't be as many results from that in this presentation. So all of our clinical surface web sampling was done in collaboration with the University of Minnesota Veterinary Medical Center. And this means we were working with a large group of individuals. We were talking to the Veterinary Clinical Investigation Center to help us with our IACUC process and consenting of individuals, the veterinary oncology technicians who were giving the treatment and then allowing me into their room to help and do the wiping after, and then as well as the dog owners who allowed the wiping of their dogs and then in clinic and then outside of clinic later too. So we are managing a large group of people and a large group of individuals for this, which led to a larger collaboration. The samples that were collected from dogs after their treatment with one of two drugs specifically. So we were looking at cyclophosphamide or Cytoxan, which is an orally administered drug. And then we were also looking at doxorubicin or adriamycin, which was an intravenous administered drug. So here I wanted to show a couple examples of some of the surfaces that we are wiping in the clinic. So these are the two treatment tables that we saw. The larger treatment table on the left here is sometimes where the dogs would be put for their IV administration for their doxorubicin treatment, as well as like the smaller treatment table over here. A lot of the times the drugs will be set on this table in their syringe before they're waiting for the dog to get their treatment. We had the pharmacy bags that the drugs were delivered in, as well as the syringe for the doxorubicin that we were able to wipe. And then we also see the oral drug administration table. So when the drugs came in, initially they were all brought together in a box, and then the IV drugs were separated from the oral drugs, cyclophosphamide, and placed somewhere else. And then the oral drugs, cyclophosphamide, were usually placed on this table, and the dogs were even given the drugs there on the floor or sometimes on the table. So for all of these surfaces, we used our standard 10 centimeters squared template, which we would wipe a surface pre-treatment and then wipe a surface post-treatment, and then look and see if we are able to identify any of the 6 chemotherapy drugs, specifically focusing on the cyclophosphamide and doxorubicin. That being said, there are a lot of areas within a clinic that aren't flat or don't fit in with 100 centimeter guideline. So for areas like that, we specifically look at irregular surfaces. So this is like for the syringe, the door handles, the cabinet handles, the arms on a chair that don't fit the template. In order to accurately calculate the surface area that's used in our method detection limit, we measure each individual irregular surface and then calculate the surface area in order to make sure we're getting the most accurate measurement possible for each surface. So as we're looking to our results from this exposure, we used the same exact method and data analysis scheme that we had set up in lab that was validated. So we conducted the clinical surface wiping, either on a surface or on a dog using our templates, followed by our wipe deabsorption practices in lab where the wipes were handled after transport from the veterinary medical center, analyzed via our LCMS method, and then the data was analyzed in order to identify potential contamination. So when we break it down, we can see that we were able to identify specific surfaces in the veterinary oncology clinic where we saw cyclophosphamide and both doxorubicin. And I'll break down each individual drug right now. So As we look at cyclophosphamide, we were able to identify it on both the door handle, the treatment table, the oral drug administration area, and then the hazardous waste bin lid. So cyclophosphamide was an orally administered drug. And with that being said, in the clinic, it was seen in different areas of the clinic compared to doxorubicin. So in these pictures that we're seeing here, cyclophosphamide is usually a pill that's given to the dogs, either on its own or in like a little pill pocket treat that they take. And these dogs usually just receive their cyclophosphamide like on the floor right by the oral drug administration area. So that being said, the drug never leaves that area. So it never comes into contact with the small treatment table. We weren't able to detect it on the outside of the pharmacy bag or on the blanket of the treatment table, but we were able to see it on the door handle, sometimes the treatment table, and then also the hazardous waste bin lid. So it's really isolated to one specific area of the clinic that we're seeing. Also, it's worthy of note to say that cyclophosphamide treatment is usually a relatively fast treatment, as it only takes as long for the dog to like orally eat their chemotherapy and then wait for a couple minutes to make sure that they don't spit it back out. So cyclophosphamide treatment can range anywhere from just a short amount of minutes to 10 minutes, where doxorubicin is usually longer. So for doxorubicin, for the surfaces that we tested, we were able to identify it on every single surface in the clinic that we swabbed and we wiped. So this includes areas like the syringe that the doxorubicin is given to the dog in, the small treatment table, which is shown right here, as well as the blanket and the pharmacy bag. So doxorubicin is an intravenous administration, and this means it is in different areas in the clinic as well as a different time frame in the clinic. So when the drugs are initially brought in, the doxorubicin is moved into a separate table area where it's laid out and being prepared for the dogs. Then the oncology technician removes the doxorubicin and the syringe from the pharmacy bag that it's in and places it on the small treatment table while they get the dog ready for the treatment. The dog is usually laying down or held down on the treatment table on top of the blanket while they are receiving treatment. So for doxorubicin, it is IV and it's time coursed out and planned out. So the treatment can range anywhere from 20 minutes that I've seen up until 30, 35 minutes for the dog. And that's with the syringe outside of the pharmacy bag, on top of the small treatment table, or on the blanket while the oncology technicians are helping hold the dog down on their table or actively giving the treatment. So as you can see, based off these two drugs that we were specifically looking at, they offer different areas for identification of the drugs in clinic that they were seen compared to one another. And there's also different factors that may influence the level of identification and number of surfaces that these drugs are seen on inside the oncology clinic. So here's the schematic breakdown of the oncology room. So we have the oral drug administration area down at the bottom, and then the IV drug placement area with the treatment table, the small treatment table, and other areas surrounding it. So when we're looking at cyclophosphamide and doxorubicin contamination in this clinic, or areas where we're able to identify these drugs, we're seeing that they're relatively localized towards specific areas where the drugs are administered or placed in preparation for administration. The oral drug administration area is mainly where we see all of the cyclophosphamide contamination, and we don't see any doxorubicin, whereas the doxorubicin contamination is more so placed in the IV drug placement area on the treatment tables and other areas in the clinic where the cyclophosphamide does not usually go. It is worthy of note, though, that sometimes with larger dogs or dogs that are hesitant towards receiving their cyclophosphamide as an oral administration, they're sometimes put on top of the treatment table where they're then orally given their cyclophosphamide instead, which could lead towards some contamination being seen at the treatment table. So that being said, our findings for specific aim 2, our specific LCMSMS method can detect both doxorubicin and cyclophosphamide at a veterinary oncology clinic through our surface wipe sampling method. all of the drugs are seen at levels that were above our method detection limit per surface, with doxorubicin ranging from 9 to 20 picograms per centimeter squared, and cyclophosphamide ranging from 2 to 21 picograms per centimeter squared. And then the drugs are detected on areas that are consistent with their application and administration. So different chemotherapy administration lead toward different contamination that we're seeing in the clinic. And then these routes of exposure and administration are traceable through this surface wipe sampling method. So our experimental conclusions for the entirety of the specific aims that we've been working on is we've developed this sensitive method that's able to identify and quantify a combination of antineoplastic drugs using a surface wipe sampling method. With this method that was then validated, we collected field surface wipe samples to assess contamination in a veterinary oncology clinic, specifically looking at an occupational exposure in an area of study in veterinary oncology and chemotherapy administration that's relatively unknown. And with this, we were able to generate preliminary data that focused on chemotherapy drug surface contamination in this veterinary oncology setting. So we really wanted to focus on creating a method that was able to identify these drugs in a more broad approach that could be then used in different occupational environments in order to increase sampling and increase worker safety. So as part of the impact of our results, our surface wipe sampling method is really meant to monitor all areas for potential chemotherapy drug contamination. So this has been a really big push in looking for the different areas and different environments where chemotherapy drugs are administered, such as hospitals, where we have wipe studies done previously, but also with new advances in technology, we're able to increase the sensitivity of our LC-MS methods and lower our LODs and our LOQs in order to get a better representation and be better able to identify potential contamination to these workers in these areas, as well as look at new areas and new occupations and environments like veterinary oncology and chemotherapy, as well as potentially even home environments where we're seeing these at-home chemotherapy infusions in order to really identify if we're seeing exposure outside of areas that have already been established and what can we do about it. Which brings us to how, with the quantitative aspect of our method, are there different remediation strategies that we can put into place, different cleaning protocols, different PPE protocols that can limit the exposure and help better protect workers, family members, or caregivers from this inadvertent chemotherapy exposure. So it's also important to note that this work had an immediate impact that we are really focusing on. As we were working through, I said, this became a larger collaboration with the amount of groups that we are working with. We focused on sharing our results with our collaborators at the Veterinary Medical Center, specifically with the oncology technicians that allowed us to come into the clinic and sample, but who are also working directly with these drugs. So initially, as we started, this was one of my first pilot experiences and pilot projects. So it was challenging to undertake this collaboration at the beginning. There was initial reluctance from some of our collaborators at the investigation center or the veterinary medical center to participate. And we think that this stems from the type of research that we do. We were going in saying, we have this new method and we can identify contamination. And that may be part of the problem. Sometimes when research, when we go out, we just say, look, here's a problem. We're able to detect these harmful drugs at levels in your clinic. And we don't do anything about it. We just report our findings and show data to them, which leaves them with a, well, what are we supposed to do now? And we're not really sure how to handle this. Our goal then is to take it a step further and take time to explain our data and disseminate to them and say, we identified this problem, but our method is quantifiable. And we can work with you and go back in and try to measure the potential contamination, but also measure potential remediation. Are there different cleaning protocols that you can test in the clinic that will then go in and wipe and see if we can see different levels of contamination? Or using different levels of PPE. How does that work, and how does that affect worker safety? So we're really trying to provide a tool for occupational workers with this specific exposure to identify a potential problem or an area of concern in the clinic, but then also identify a remediation or another helpful strategy that we can leave the clinic with, rather than just sharing our data and that there may be a problem. So we were able to do that. We shared our results with our collaborators at the Veterinary Medical Center. We had all of our research disseminated at group meetings with the oncology workers who were impacted by the results. And this really helped. It prompted samples about additional sampling or new strategies to reduce contamination. They were able to give feedback, which helped us figure out new steps and new sampling guides in our study, potentially other areas that we weren't including that we wouldn't know about because we're not a daily worker in that environment. And it really helped us continue the collaboration that we have with the oncology department there to help them, but also help us with our research at the same time. This study also really helped me. It helped me develop my research skills immensely. It provided me with how to interact with peers outside of my direct advisory team. And it really formed like a hybrid space between research and outreach. I was building collaborations by working with the oncology people and staff who were directly affected by the research that I was doing, but also larger collaborations, including people from the Clinical Investigation Center, as well as the dog owners, where we were sharing information. I was going to conferences and presenting my results and learning about other communities that are potentially affected. So this research was really like a multi-level focus and a multi-level benefit. We were able to broaden the reach of our project by reaching out and collaborating with others, and specifically the affected population and the community, to better address their needs and their concerns, which prompted us with more questions and more areas where we could complete our research and apply our method. So for the next steps of our clinical wipe sampling, we are collecting more surface wipe samples and more dog wipe samples. So that being said, is our goal with our dog wiping samples as a potential secondary source of this chemotherapy exposure that could travel outside of the oncology clinic and maybe affect those caregivers or community members that aren't expecting to it. And it's this inadvertent exposure that they don't know how to deal with because they aren't educated and they don't know about it. So what we're doing is we are collecting dog wiping samples where we wipe the dog in 3 separate areas around their mouth, down their back, and their hind legs, in order to try and get a sample of potential exposure that homeowners may see or dog owners may see when they wipe their dog. So what we're doing right now is we are wiping the dogs 1 hour, 3 hours, and 5 hours after their chemotherapy. And then we're giving these owners a take-home kit alongside a video with instructions and more information of how to wipe their dogs 24 hours post-exposure, because we really want to look and see if there is a difference in the levels of chemotherapy drugs that we're able to potentially identify on a dog outside of a oncology clinic environment. So here's an example of our, you saw an example briefly on the last slide of our training video demonstration that is provided to all the owners when they look and sign up and consent for our study. We give them a take-home kit with a vial, a wipe, instructions on how to wipe their dog 24 hours after they get their treatment. Then they send the sample back to us. And then how I'm going into the veterinary oncology clinic and wiping the dog at different hours post-exposure. And then we're analyzing those results right now and looking to see if we can identify any chemotherapy drugs on the dogs after their treatment. So what is the importance of this research? Companion animal chemotherapy administration is increasing in the US. That being said, each clinic that we've been talking to has a different protocol and different practice for the handling and cleaning of hazardous drugs. Some of the individuals and dog owners that we've talked to or the clinical staff say that sometimes they have the drugs given to their owners and the owners give the chemotherapy drugs at home. Sometimes the owners leave the medical center and they have a little brochure that tells them information about the type of chemotherapy drug that their dog is receiving and maybe best practices around handling the dog X amount of hours or days post-treatment. Other times, we don't get a lot of information and we just hear about people who pick up their dog and they weren't told anything different or otherwise. And this can also be said for the veterinary oncology technicians who are working in the clinic. A lot of the times the clinic doesn't have specific cleaning protocols or decontamination protocols for these hazardous drugs. Currently, the exposure limit for these drugs is not set, so it's just as low as reasonably acceptable for these antineoplastic drugs. So most clinics don't have a specifically outlined detailed protocol of the cleaning that's required for them. So there are a lot of questions that can be posed, like should trainings be developed for the veterinary medical staff on handling of handleless drugs? Are there different courses or webinars that should be taught specifically looking at this topic? It all ties back into like do we need more research on this topic? In my personal experience, the staff didn't know about the potential exposure from chemotherapy drugs on contaminated surfaces. And then they didn't know about the potential health risks of this environmental contamination. That being said, like with our method, it represents the potential for dermal risk of exposure, as the wipe sample that we are using and collecting represents a surrogate for the potential exposure from the dermal skin contact with the antineoplastic drug, but it's still a method to show the potential contamination that's seen at the clinic and identify and quantify this contamination in order to form different remediation strategies. So through my collaboration with the veterinary oncology team, it really fostered and built this collaboration and provided us an area to accomplish our research. We shared all of our relevant information about potential chemotherapy contamination directly with the community members and with the oncology staff and the technicians. And we're really hoping to identify interventions to reduce the potential for this hazardous exposure and work with them in order to conduct additional sampling and really identify the areas where we need to improve on our different cleaning agents and PPE use in order to make a safer workforce and a safer environment. So moving forward, these results provide data to inform on the levels of contamination that are seen in a veterinary oncology clinic. And we're currently working on identifying potential secondhand exposure from dogs outside of an occupational environment. It sets the stage for surface-wide sampling for all areas of potential chemotherapy contamination, whether that's in an occupational setting, such as a hospital or an oncology clinic, or in a veterinary setting, or potentially in home environments where you can go and complete the wiping. Additionally, as we've said, it addresses the growing problem of antineoplastic drug contamination outside of an occupational setting with the increasing administration of at-home chemotherapy treatment. So overall, it's a very applicable method towards clinical wipe sampling in order to identify antineoplastic drug contamination in a sensitive and accurate way. That being said, I would like to conclude my presentation here. I'd thank my advisors as well as the Masonic Cancer Center for all their mass spectrometry support, the Midwest Center for Occupational Health and Safety for their funding for this project, and all of our collaborators at the Veterinary Medical Center and the University of British Columbia. I'd be happy to take any questions at this time. If you would like, that's my name and my email address right down there at the side. Feel free to send me an email if you have any questions, or that's the link to our website as well, where you can learn more about some of our other projects that we're currently conducting over here at the U.
Thank you so much, Andrew, for that presentation. So we actually have a lot of questions.
Okay.
So the first question is, please provide more details on how the surface samples were collected. Did you use a secondary wipe for each sample to ensure the collection efficiency was maximized?
Yeah, I can show you. I can kind of, I'll have this video play out while it kind of shows the different types of wipe samples that we do. So for each wipe and each area, it's an individual sample. So when we would go and we'd take and we'd collect samples from the different surfaces in the clinic. So each surface, like the treatment table, would get its own wipe that's then stored and processed separately. So for example, if a dog had received their cyclophosphamide treatment, the different types of wipes that I would collect would be the like the door handle, the treatment table, the small treatment table, the pharmacy bag. They would all have their own individual wipe that would individually work its way through our deabsorption protocol, and they would each be treated as a separate individual sample that was then run and analyzed using our LCMSMS method. So none of the wipes were shared across the samples. The only wipe that we're currently sharing for the sample is for the dog. So as we wipe the dogs, we only use one wipe for the face, the back, and the hind legs. And that's to maximize potential identification and like exposure results from the dog. Because as we have found out, when you wipe something that's not a smooth stainless steel surface, you have a lot of loss to your recovery. So as we're wiping things with like fur or hair, we want to increase our recovery. So we're just using one wipe.
Okay, thank you. And so a follow-up question to that from a different individual was, what wipe were you guys using? They listed a brand, I think it's Wipe All 60. And then they asked like, what was it moistened with?
Yeah, so we use Whatman filter paper as our wipe, a specific grade. I can't remember the grade of Whatman filter paper off the top of my head, but we use Whatman filter paper for all of our wipes. And we have two different solutions. So for our wipe wetting solution and our wipe deabsorption solution, we use 80% methanol and 50% methanol with 0.1% formic acid, respectively.
Okay, thank you. And the next question is, can you discuss the different work practices used by the technicians to deliver the drugs which contributed to the exposure?
Yeah, so sometimes it gets tricky to fully understand the whole inner workings of the veterinary medical center, because just like hospitals, they're very big and they have a lot of strict protocols too sometimes. So initially when we were proposing this research, we had asked, are we allowed to go into the pharmacy and wipe specific surfaces or areas in the pharmacy where the drugs are prepared, where they're loaded into the syringes and packaged into bags? And we were not allowed to go into the pharmacy or we didn't have that clearance to go in there. So we weren't able to wipe those areas. So that chain of like understanding of the drug preparation and traveling is kind of unknown to us. It's lost. But for us, when we do start is when the drugs get to the clinic. So usually one of the oncology staff or technicians brings the box from the pharmacy to the clinic, and then it gets set down in the oncology administration room. And then that individual oncology technician helps lay out the drugs for the dogs that day, depending on how many there are in the different respective areas. So the main point of exposure starts when those drugs are placed in those separate areas, and then when they were traveling from that box to the oncology administration room. But we don't know about like the first part of exposure and that route. We only know what happens when we see the drugs placed in their areas. In the oncology administration room where the dogs are given their chemotherapy. So that's where we started building our exposure of where do we see the cyclophosphamide, and then is this consistent with the places it's placed in preparation for treatment, and the areas where either while during treatment or after treatment, the oncology technicians are frequently touching or using.
Gotcha. And so the next question, well, I guess I'll start with the comment and then the question. So there was a comment that said, your work is similar to what Dr. Polovich and I looked at Georgia State University for hospital technicians and physicians administering chemotherapeutic drugs. Work practices were a primary problem along with decontamination of the room and staff. And so the question, I guess the kind of follow-up question to that is, did you collect wipe samples prior to the delivery of the drugs in each room to determine cleanliness?
Yes, we did. So we collected both pre and post wipe sampling for the dogs and their treatments. The results didn't vary greatly. So we were able to identify a lot of the drugs, both pre-treatment as well as post-treatment, which indicates a larger problem that we're seeing in the oncology clinic, where we're just not seeing a lot of either correct PPE protocol use or following, or cleaning strategies. And then that can also like fall back to just not knowing on the proper decontamination protocols and cleaning strategies that need to be put in place when you're handling these types of hazardous drugs. So we did sample pre and post treatment for all of the dogs that we collected in the clinic, and we didn't see a large difference between the pre and the post samples for the dogs. That being said, some days when we went in and sampled, we often sampled dogs who received their treatment like back to one another. So it would involve like a lot of wiping of the same surfaces multiple times over the same day in a relatively close time frame. So when we were conducting those wipe samples, we did start to see changes in the pre and post sampling, but that could also be because we were sampling the same door handle 6 times over the course of an hour with multiple wipes per each sample. But yes, right now we did have pre-post sampling. We didn't see a large difference between the 2 time points that we were looking at, and we think it may be something larger like improper decontamination protocols.
Okay, the next question, well, I guess this is a comment, but the comment is, please consider sharing your results with the American Industrial Hygiene Association at the professional development courses, PDCs, and annual education sessions. So it's a nice comment. And okay, so the next question is, have you reviewed existing literature on the elimination data for these drugs in dogs? If so, based on that data, what do you expect from the dog wiping data?
I have not reviewed that data, but I'll take note of it now, and I'll take a look at it and take it into consideration too. Thanks for sharing that with me.
Okay. Next question is, for the testing that you conducted up to 24 hours later, how did you control for what may be excreted, skin, urine, feces?
So we were specifically looking, it's hard to say because the dogs metabolize the drugs differently than humans metabolize the drug. So what we were taking into consideration for the type of metabolism and the type of surface wipe sampling that we would see is specifically around our like wiping areas on the dog. So we wanted to wipe around the mouth, which would maybe be any saliva or anytime the human would be in contact with the dog's mouth when they kiss their dog or the dog licks them. Down the back, because that's the most common area that you pet your dog with potentially any skin. And then the inside of the hind legs too, where you may get potential urine residue. For this experiment, we are not collecting any biological specimen. So we are not collecting any urine, blood, or hair from the dogs. It's just exogenous wiping of the dogs. So that's what we took into account, specifically looking for maybe potentially how the dog can metabolize it and how the owner of the dog would come in contact with the dog and potentially be exposed.
Okay, thank you. The next question is, should you consider the reproductive effects to technicians and veterinarians from exposure to these drugs?
So it's hard to say again. The paper where I referenced the reproductive effects and other effects like spontaneous abortion came from hospital workers who were working with the chemotherapy drugs, and they were collecting urine samples, and it was over a chronic exposure over a long time. So it is important to look at lower levels of drugs that you may, or lower levels of contamination from chemotherapy drugs that you may be exposed to in a setting. But again, it's also important to note the type of sampling and the method that we use. So we used a wipe sample to serve as a surrogate for a potential risk of dermal exposure. That being said, we can't inform direct risk based off our results, based off the levels that we are seeing too. It's not the way that our specific method is representative of the exposure. We're just the potential risk for exposure. But it's important to keep into consideration that we are able to identify the chemotherapy contamination on surfaces in oncology clinics. So it is there. And theoretically, there could be chronic long-term exposure at low levels for a long time. So you still should take into account and think about what you've seen in the past from chronic low levels of exposure with your adverse health outcomes, and apply it to the specific veterinary oncology setting that we're looking at.
Thank you. The next question is, great presentation. Thank you for sharing. I'm interested in the detection threshold and remediation strategies. What thresholds warranted remediation strategies, anything above detection limits? That's the first question.
Yeah, so for the first question, we calculated an LOD and an LOQ using the standard signal to noise ratio for mass spectrometry, whether it's 3 or 10 respectively for the LOD and the LOQ. But then we specifically also used our own method detection limit per sample and per surface in order to accurately say that what we're seeing is coming from the area that we're sampling, and it's taking into account extra factors in our method that may influence the results. So our method detection limit is higher than our actual LOD and LOQ that is set up by our mass spectrometry instrument, because that was using just chemotherapy drug in solution that was then spiked and analyzed. It wasn't an accurate clinical sample. So right now, the guidelines are as low as reasonably acceptable, so there aren't really any understanding for what should be a hazardous dermal exposure or hazardous potential exposure in an occupational setting. There is no exposure guideline for these drugs outside of like a direct exposure or metabolism or injection as someone who is receiving treatment for the drugs would receive. So when we're talking about a dermal exposure, we really don't know. So it would be interesting, and it would be part of the additional sampling that we're working on with the clinic to test different remediation strategies to find the most effective one that can lower the levels of the potential exposure to levels where we're not able to accurately see them or identify them in the clinic, because that would really add a lot more confidence and really increase the feeling of like safety that the workers are seeing. So I'm not exactly sure. That's hopefully why we're doing more research like this, in order to better inform on like different decontamination protocols that can be used in the clinic.
Thank you. So a follow-up question was, how was success measured with implementing PPE, or what PPE was recommended based on results?
Yeah, so right now, what we use in the clinic is we use a specific type of thickness of gloves for when you're handling the chemotherapy drugs. So there's a specific recommended gloves for the chemotherapy, and it includes double gloving and different types of gowns that are used. We haven't specifically tested any decontamination protocols or cleaning protocols that we're looking at. There are a couple different agents that are interested in our research, whether it's like a bleach or another different name brand like Paradox RTU, like a hydrogen peroxide cleaner. But then you start dealing with those strong oxidizing reagents that can react with the drugs as well. So there's different types of protocols, but we haven't directly tested any of them yet. That's part of the sampling that we're working on with the veterinary oncology clinic. Right now, we're mainly focused on finishing up our dog wipe samples in order to move on to the next step.
Okay, so the next question is, what are the results post-treatment? Did they shed the drugs?
For so if you're talking about the results post-treatment with the dog samples that we've seen so far, in our preliminary wiping that we've seen when we were just testing the dogs 5 hours post-treatment, we weren't able to identify any of the chemotherapy drugs on the dogs based off our surface wipe sampling that we were testing, where we then further pushed it out to 24 hours to see if the metabolism maybe was not enough in the dog. So we increased the time. But as of like 5 hours when we first initially tested our wipe samples in the dogs, we weren't seeing any of the specific drugs.
Okay, So we have 5 minutes left, so maybe we can get through 2 more. Andrew, if you don't mind going to the slide that had your email, so those whose questions weren't answered
Yeah,
can
of
maybe
course.
direct it towards you. Yeah, thank you. So the next question is, hi, Andrew, thank you for sharing your research. From your literature reviews and research, do you see an established occupational exposure limit being set for docs in the future? Thanks.
So far from my literature reviews and what I've seen, I would hope so that one would be established. Specifically looking for dogs and the different types of drugs that they've seen. A lot of the drugs are very sticky, like doxorubicin, and it's really hard sometimes that they just want to persist and stay around. So I think it's really important, specifically with these types of workers that we're seeing with veterinary oncology workers, that more information around occupational exposure limits are available for them in order to increase their safety. And I think the only way that it'll start happening is if more research comes out about different levels that we're seeing in clinic, in order so that people are able to be better informed of what is a safe level, what are average levels that people are seeing, are there associations with these levels and adverse outcomes. And I just don't think that there's enough research out there right now for them to say that, but I hope so. I hope that occupational exposure levels for these hazardous drugs and this specific type of risk from surface sampling and different surfaces leads towards an occupational exposure limit.
Thank you. So the next question is, are you aware of any similar studies of contamination research animal settings when toxic or novel compounds, not always chemotherapeutics, are administered to research animals, such as rodents, and the animals that are maintained in cages with bedding, which must be changed by animal care staff?
I'm not familiar with any other studies. I'm sure they're out there, just like there are other surface wipe sampling studies and methods that are being done in different hospitals and clinics. It's a really interesting approach to relate it to research and other different types of novel compounds and chemicals, especially when you're thinking about your animal research staff that's helping out with all this research and what they're potentially exposed to and how it could be even more like unknown or unstudied as like a widespread chemotherapy drug that's used. So I'm really not sure, but that's a really interesting point and topic to look into.
Okay, so I think we can do one more. So the last question is, could the findings in this research potentially apply to R&D facilities where in vivo studies are conducted?
Yeah, I certainly think so. I hope that the findings of these could be used as broadly and as applicably as it could. And then I also hope that the method could also be used like as broadly and applicably as possible. We kind of tested and made the parameters so we are able to do simultaneous drugs just in one method and in one swoop. So if different areas are able to apply the method and use it and specifically try to identify these drugs, I think that's great. And I hope it gets a lot of use.
Okay, so thank you so much, Andrew, for being here today and for presenting on this amazing topic. And as a reminder to all participants, we will be sending recordings and evaluations tomorrow to all who signed into Zoom today. And thank you so much for your participation and support of the COEH department. All right, everybody. Bye.
Thank you.